The organizing committee of the Ganga Anesthesia Refresher Course 2020 is privileged to present the GARC Professional Excellence Award to Professor Dr. M. Ravishankar of Pondicherry, India, for his phenomenal contribution to the fraternity of anesthesia. He served as the professor and head department of anesthesia at GIPMA Pondicherry, after which he took over and served as the professor and head department of anesthesia, later Dean and Director of Medical Simulation Center, Chairman of Quality Control and Patient Safety, ITC Coordinator of AHA, Director E-Learning at the Mahatma Gandhi Medical College and Research Institute and Sri Balaji Vidyapeeth, Pondicherry. He has delivered 10 orations. He has been awarded FRCP by Royal College of Physicians and Surgeons, United Kingdom 2012. He has won the Lifetime Achievement Award for Progress of Anesthesia in India by the British Association of Indian Anesthetists in 2007, appointed as member of Ethical Committee for Testing of Ventilators in Human Beings, consultant for designing anesthesia and intensive care ventilators. He has mentored several hundred anesthesiologists across the globe. We are really fortunate to present the Professional Excellence Award to Professor Dr. M. Ravishankar for his phenomenal contributions and inspiring life as a teacher and mentor. Presenting to you Professor Dr. M. Ravishankar.
Very good morning, good afternoon, good evening. I have to say all this since the audience is there around the globe. At the outset, I would like to thank the organizers of this virtual conference, which has got registration of more than 5,000, for asking me to take part, and special thanks to Dr. Baluvenkat, who thought about felicitating me in this particular conference. I am happy to have someone like him who can mirror my thoughts about having a department of perioperative medicine and pain relief, not just a department of anesthesiology. I thank all my peers who have said such good things about me. What I am today is because of the interaction that I had from people like them who have been my students at some time, the colleagues, and then at the helm of their affairs now. And I bow down to them for all the gestures. And I bow down to my institute, GIPMA, where I have worked for about 30 years, gaining all this experience, and to the present institute, Mahatma Gandhi Medical College and Research Institute, in which I am working now. For this Thanksgiving talk, I have been asked to talk about small interventions and big outcomes. Small and big are relative terms. So whatever is big now may not be so after some time. I had grown up with this particular specialty for the past 45 years, and a lot of things have changed in that 45 years. So I will not be talking about the relative things that have happened, but I would like to concentrate on something that is eternal, which has to be paid attention to at all times. That is patient safety. Now, I will start with a small incident that happened when I was a second year resident in anesthesiology. I had to anesthetize a 3-year-old child for suture removal after a syndactyly repair. First case in the morning, I had come, I had checked the machine, and then I have started the case with nitrous oxide oxygen and halothane. Child was induced, but it was not going under, and halothane was increased to 2%. Even after 5 minutes, the child was not going under. Surgeon said, "Don't worry, I will finish the case." So he started cleaning and he took off the sutures and he started bandaging the fingers. So I let out a sigh of relief because the child had inspirated stridor along as well as it was moving all the time. Then after that I cut off the halothane and nitrous oxide and gave 100% oxygen. The stridor disappeared and everybody was happy. Suddenly the surgeon said, "The fingers are looking a little blue. Is my bandage a little tight?" Then I looked at the child. The child was not breathing. Slowly it stopped breathing, and then that rang a bell on me. So I took the laryngoscope and did a laryngoscopy to see is there anything that is there which is obstructing the flow, or is the child, what is happening. Then as I did the laryngoscopy and exposed the vocal cords with the tube in my hand, the child took a gasp. And then I thought, why put a tube if the child is going to breathe, and just waited for another 30 seconds to see whether the respiration will regularize. And yes, definitely the respiration regularized with a few gasps and then a regular respiration. What was surprising was breathing room air, the child became pink, the cyanosis disappeared. So I settled the child. I did not put the mask back. I took off the laryngoscope and allowed the child to breathe, and then looked back into the machine to see what is happening in the machine. And I traced the pipeline from the oxygen yoke right up to the ball outlet to find that oxygen pipeline has been connected to the nitrous oxide outlet, and that is why the child was getting 100% nitrous oxide and not oxygen. Okay, if the child has been intubated and ventilated, it would have been the end of the child. Not only the end of the child, it is as well as the end of my career. Because if you look at it, I had come in the morning, I had checked the machine, I had started the case, and then to find that incident like this happened. So this is what is the lesson that came to me right in the beginning of my career, and I said, I will concentrate on details. I will concentrate on patient safety and pay attention to details all the time. That had been my motto for the past 45 years. Not only during anesthesia, I said I will pay attention to everything that I do. And so this has led me to a situation where I could detect the faults in the machines, in the ventilators, in the breathing circuits, and even in anesthesia much before anybody else could detect something is wrong. That is, then whatever I do, it is always patient-centered and the patient safety as the primary goal. So I am going to talk to you about this patient safety, and anytime I get a chance, I have been talking about it, conveying the thing that this should be the priority of every anesthetist who is anesthetizing patients. Patient safety is the primary goal. Now, why is that? You find that, look at the literature, 100 years after discovery of anesthesia, still the safety has been equated to escape from death. That is what it was in 1948 and 49. Fortunately, as I grew along with the specialty, the focus shifted the last quarter of the century between 75 and 2000. The focus shifted to safety of anesthesia. There were long-term research to find out the safety of the drugs before they were put into clinical use. A thorough understanding of the pharmacokinetics and pharmacodynamics were done, and it helped in managing patients. There is also development of drug delivery systems which are precise so that the drugs can be delivered according to the surgical demand with an early recovery happening. There is also redefining of anesthesia gas delivery system to prevent delivery of hypoxic gas mixtures. All this put together, finally, because of the media that went wild in 1984, the equipment designs, the very stringent safety standards were introduced for anesthesia machines and monitors. It is not just enough to say that we have stringent measures, but the manufacturers were made to comply with all these standards. That is more important. If that is not there, then there will be a diversity. Then protocols for checking these machines before using them is made mandatory, and not only that, continuous monitoring of the equipment, performance of the equipment, and the warning signals have been introduced into the machines. And with all this, the minimum monitoring standards were spelled out for anesthesia in 1988, which included presence of a qualified anesthetist, oxygen analyzer, ECG, pulse oximetry, non-invasive blood pressure, and end-tidal carbon dioxide. This is a game changer. That's what I will say. Why do I say that this is a game changer? Because after complying with all these minimum monitoring standards in the institutes that I've worked, deaths due to hypoxic gas mixture, unrecognized esophageal intubation, circuit disconnection and inadequate ventilation were not heard of for the past 25 years. Deaths implicating anesthesia as a major cause came down mainly because of the transparency and awareness of the patient's condition to the entire team who was working in the theatre. Should we at this juncture be talking about mortality? If you ask me, the answer is a big no, because mortality does not reflect what is the status of anesthesia. It should be a reduction in the morbidity that should determine the safety and not the mortality, because mortality reflects only the death. Analysis of the morbidity is more reflective of the safety levels. Auditing at regular intervals is useful to correcting in a closed environment. Policy making and incident monitoring is important. Incident reporting is needed for wide policy making. What we did in 2002 in JIPMA, we started collecting data. We had set up a computerized database. We had a Dropbox in every theater to fill up the forms and put. And we also had a person actively soliciting information from people about any critical incident that happened for that particular day. So we started collecting critical incidents, and small intervention that I did, because all these are being done all over the world, small intervention that I did was to promise everybody that anonymity will be maintained and no punitive action based on the incident will be done. And that gave a lot of encouragement to the residents and the faculty to report the incidents as and when they happen. The incidence is defined as any deviation from normal process at any particular time, and they were classified as no harm, near miss, adverse, and death. And also information about the place, time, and description and management of the case also were taken when the report is done. Coding of the incidents was done at the end to maintain anonymity, and then the following codes were used to define what is the incident, and then a root cause analysis was performed to find out the reasons and to extrapolate them to whatever is happening. There were a total of 17,918 anesthetics performed. Total incidents reported were 156. There were 45 no harm events, 64 near misses, 41 adverse events, and then 6 deaths. This is not a big number if you look at the total number of incidents. We know that no harm incidents are not reported quite often, and that is why the incident level remains low. When we analyzed these incidents, what did we find? We found that the incidents occurred predominantly in ASA 1 and 2 patients in elective surgeries predominantly, not during the emergencies. So you had about 114 incidents in elective cases, and ASA 1 and 2 total to about 97 plus 38, about 135 patients. And then we analyzed what are the monitors that were used in all these cases. We found that 92 patients were there who had near miss and adverse events, and pulse oximeter, ECG, and NIBP have been used in all the 92 patients. ETCO2 has been used in 48 patients. This differed because some patients were done under regional anesthesia and the ETCO2 was not used. What about machine monitoring? Oxygen analyzer and nitrous oxide analysis were used in 48 patients. Agent analysis has been used in 28 patients. So, out of all these monitors, what picked up the incident early? That is what we were interested in, and we looked at and analyzed it to find how these incidents were picked up. To our surprise, we found that it is picked up by a senior anesthesiologist who goes from one OT to another to supervise when the juniors are doing cases. This is how the incidents were picked up. It is not the monitors that picked up the incidents and showed it to you. It is anesthesiologists who picked up the incidents well before the monitors could give alarms. What were the incidents? Inadequate precautions, inadequate preoperative assessment, lack of vigilance, checklist not followed, lack of communication. All this amounted to around 90%, and lack of skill is only about 11%. So you find these are human errors. These errors cannot be picked up by machines. So these are picked up by humans who have been supervising them from time to time and prevented the incidents from happening because they have been picked up much earlier than when they could happen. Still, we had 46 adverse events and then 6 deaths. Some of them might be because of the patient's condition. Now, I just want to emphasize that fact only, that whatever is the machine, whatever is the monitor that you use, it is not going to pick up the incidents well before an anesthesiologist could pick up. And it is the anesthesiologist who picks up much earlier than this machine. So we should be depending on a qualified anesthesiologist present at the head end of the patient at all times. That is what is much more important than having fancy monitors and relying on these monitors. Now I said my motto is pay attention to details. This paying attention to details has given me a lot of rewards. What do I mean by pay attention to details? This is what I do. I do a scan as I walk into the theater. What do I scan? As I go, I look at the sister's tray, look at the suction bottle, look at the blood loss as I walk to the head end of the patient, and look at the surgical field, look at the patient's breathing, look at the abdomen to see there is a uniform movement of the abdomen to indicate the satisfactory breathing. Check the pulse, check the peripheral perfusion, turn your attention onto the endotracheal tube fixation, follow up with the breathing circuit right up to the circle absorber, look at the valve functioning, look at the bellows that are moving up and down, if the flow out of the patient is satisfactory, and then bellow movement, follow it up with to the flow meter settings and then on to the vaporizer. After looking at all that and looking at the patient's condition, then you look at the monitor to see what the monitor is showing you and corroborate whatever is being shown to whatever you have observed. And in this particular scanning that I've recorded now, I find that blood pressure has not been recorded for the last more than 10 minutes and nobody has noticed and then taken any action for that. So these are the things that you can pick up. And also you will find quite a few things about the patient and the correlation with the anesthetic monitors and equipments. I just want to give you an example what is possible, and this is a case that I walked into. You can just look at the timing. I walked into the theater. This is the patient, 3-year-old child, who has come for abdominal perineal pull through for imperforate anus after having a colostomy. So this child was anesthetized, Cordal was given for pain relief, and putting the patient on lithotomy position for surgery, extended lithotomy as I walked inside. And when I came inside, what I found was the monitors were showing everything normal. As usual, I went around and then put the hand on the pulse. When I put the hand on the pulse, what I found is I did not feel a pulse. And what I did, I told the senior resident, load up adrenaline. He was not responsive. He looked at the monitor and said, everything is fine. Why do you need adrenaline? That is the expression he showed. So I really have to shout at him to say that load the adrenaline. And then I took the stethoscope and auscultated the chest for heart sounds, and they were muffled. There was no pulse. So as the time went on, you find that within 2 minutes, the heart rate fell down to 58. There is no ETCO2 tracing that has come up. And so that is the time, that 3 minutes that has taken to react for the monitors to identify, when I have already said load up adrenaline because the child does not have a pulse. And you find that you trace that, you go, you cut off the oxygen at this, nitrous oxide at this time, and give 100% oxygen. And pulse oximeter was all the time reading 98, 95 in that range. Heart rate was 53, no ETCO2. We started massaging and we gave adrenaline and continued with the massage. And you find in about, at this particular time, this is a 6 minutes after that, we could increase the heart rate. It came up. we could see that the carbon dioxide has come up, and it has came up to 33, and then it went up to, and the heart rate went up to 168, and saturation picked up to 95, 99, like that. So we continued to ventilate this child till the ETCO2 stabilized. So what does all this mean? It is not just one person. Yes, we have revived the child without any morbidity in the child, because we have followed it up and then took up the case after 2 days to complete the surgery. What I want to say is, what is more important than individual identifying it is the perception. Whatever is going on around, you should have a perception of what it is. There should be assertiveness, and there should be proper communication, and there should be a teamwork. Unless there is a teamwork, you are not going to succeed in whatever you are doing. So with this, I'll finish my talk to say that thank you for giving me this opportunity. Please pay attention to details. If you pay attention to details every time, all the time, you will pick up incidents much before they happen, and then you will take corrective action. Thank you very much.